Teachers, good morning. Sir, I would like to know who, according to you, is a candidate for wait and watch policy? Is patient motivation and the readiness for strict surveillance the only criteria? Number one. Number two, how does the histology make a difference in the wait and watch policy? And does the NACT FLOT regimen done preoperatively, does it change your management? How does that come into the wait and watch policy? Thank you.
So I think there are 3 or 4 questions in there. The first is, who is the ideal candidate for a active surveillance? The first important thing is they need to achieve a clinical complete response, CR. That is assessed at, as per the, if you're talking about a SANO trial, at 6 weeks and 12 weeks after completing chemo-RT. That is the first criteria. If they don't achieve that, they are anyhow they go for immediate surgery. They are not taken up for active surveillance. And the second question was, does the histology differentiate between the options? So regardless of histology, if they achieve CCR, they are taken up for active surveillance protocol, adeno or squamous. The likelihood is more for squamous, as we know, as I will be discussing in the next talk. But even adeno also, if they go into CCR, they can be taken up for active surveillance. The last question is, does neoadjuvant chemotherapy only with FLOT type regimen impact the active surveillance protocol? So the answer is, as of now, we don't know, because no such trial has been done like the SANO trial, which included only neoadjuvant chemotherapy alone. But probably yes, if you look at it from the practical point of view, patients who achieve a CCR with neoadjuvant FLOT, more and more in the future, probably they will also be taken up for active surveillance if they agree to the intensive surveillance schedule. I hope that answers all the questions.
So just disagree on one point, that as of today, we cannot advise wait and watch even if we achieve CCR after FLOT. We have no evidence to do so. Secondly, more and more adenocarcinomas of G junction and esophagus are going into FLOT regimen because we have better overall survival based on the ESOPEC trial. So if we have a patient today who has esophageal or G junction adenocarcinoma, depending on institutional protocol at Basudagarakam, the protocol today is the patient would go into FLOT. And as of today, obviously in the future it might change, but as of today we have no evidence to advise wait and watch post neoadjuvant chemo. It might come in the future.
These are all perioperative regimens, perioperative. All the trials that have been done, IO chemo and chemo alone. So the Matterhorn data and the FLOT, they're all perioperative regimens. So we cannot automatically apply them to adeno as of yet.
Absolutely, absolutely. This is all we just extrapolating. Yeah, this is not as of now. For if you're going for a perioperative approach, surgery has to be a mainstay of treatment in the middle of the neoadjuvant and adjuvant component of the treatment. But the question was that, can it be done? So maybe in the future, we don't know as of now, but only if the patient is extremely either unfit for surgery or not willing for surgery and then keen to be on active surveillance, that is something which can be thought about.
As a matter of fact, there is no part in the body where you can give chemotherapy and wait and watch. It's as simple as that. You need a local treatment, and radiation could replace that. That is the current evidence, is it not?